The next section, we're going to talk a little bit about cocaine, and we're going to cover cocaine pharmacology and there's some systemic effect that differentiate cocaine from other local anesthetics like lidocaine. Cocaine is an ester of benzoic acid similar to other ester-type local anesthetics, so it contains an aromatic residue that you can see with blue circles and a tertiary amine in red circle that are connected by an ester linkage. Commercially, the cocoa alkaloids are hydrolyzed, benzoylated, and methylated to the base cocaine. And the hydrochloride salt results in a powdery white crystalline substance that has a pKa of 8.6 and is water soluble. The available solutions are 1 to 10%, but 4% is most commonly used for topical application. And the maximum recommended dose is about 1 to 3 milligram per kilogram, depending on the source you choose. Cocaine is readily absorbed across mucous membranes and into the systemic circulation, and it usually has a half-life of about 30 minutes to 1.5 hours. And because its metabolism is dependent on liver and plasma cholinesterase, as its half-life can be significantly prolonged in patients with liver disease and those with atypical cholinesterases. Now, similar to other local anesthetics, the action of cocaine is from the effect by blocking the influx of sodium ions across the neuronal cells. And systemically, cocaine acts as a norepinephrine reuptake inhibitor, so we get sympathetic stimulation manifested with mydriasis, hyperglycemia, hyperthermia, and the cardiovascular effects of the sympathetic system. The initial effects of cocaine and CNS are stimulatory, causing euphoria and arousal. Cocaine is, as a result, a potent behavior reinforces. It has a biphasic action on seizure threshold and it acts as an anticonvulsant at low doses, but as you increase the dose, the seizure threshold will go down. The cardiovascular actions are also dose dependent. So at low doses, cocaine exerts primarily a vagal effect, so the patients can have bradycardia. But when you increase the dose, it can lead to elevations in blood pressure, tachycardia, cardiac arrhythmia, and even myocardial ischemia from the increase you get from the work of the heart. It can actually cause accelerated coronary artery disease, induce coronary spasms, and reduce the blood flow to the heart. If inhaled, it can result in alveolar hemorrhages and pulmonary edema. And cocaine use has been associated with ruptured aortic aneurysms, infective endocarditis, and vascular thrombosis, particularly in IV use of it, and myocarditis, dilated cardiomyopathy, ruptured cerebral aneurysm, and subarachnoid hemorrhages. Now, in current anesthetic practice or in general practice, cocaine is primarily used topically to anesthetize and vasoconstrict the mucous membranes of the nasal cavity and nasopharynx during nasal procedures. The ENTs who still use it apply 2 ml of a 10% solution on cotton pledgets to put it on branches of the anterior ethmoidal nerve and sphenopathine ganglia, and this will dilate the nasal passages. Alternatively, a 5% spray or a 10% paste can be used to get the same result. But as you can imagine, because of the potential for toxic side effects and the abuse potential, the use of other drugs has been advocated. And 1% lidocaine and 0.5% phenylephrine solution, known as cofenilcaine, has been shown to be as efficacious in dilating the nasal passages as a 5% cocaine solution. Ocular uses is really limited nowadays and is more of a historical interest because it can cause corneal damage that can result from the vasoconstriction. And cocaine may potentiate the neuromuscular blockade either by reducing the acetylcholine release at the neuromuscular junction or by decreasing the postjunctional membrane sensitivity. So, if we give a normal dose of paralytic to someone who also gets cocaine, that patient's neuromuscular blockade can last longer. The use of cocaine is contraindicated in patients with hypertension and in those taking tricyclic antidepressants or MAOI inhibitors. And cocaine abuse by parturients or pregnant patients can lead to multiple OB complications, including preterm labor, placental abruption, and stillbirth. Cocaine-induced thrombocytopenia can increase the risk of associated with placing an epidural or spinal anesthesia, and ester-type local anesthetic agents may compete with cocaine for metabolism by plasma cholinesterase, prolonging the effect of both agents. Now, this is a summary slide of the effects of cocaine versus lidocaine, and as you can see, cocaine increases heart rate, but low-dose lidocaine has little effect, and lidocaine toxicity is manifested by severely reduced heart rate. The effects on blood pressure is similar in that cocaine causes hypertension, but lidocaine causes no change, or with toxic levels, severe hypotension. And finally, cocaine causes CNS stimulation, but low-dose lidocaine causes a slight depression of CNS, so patients feel a little bit relaxed. But as we increase the dose, we see stimulation like seizure activity, followed by severe depression of CNS, such as a patient going into coma.